Hi, everybody. It's Susan Thornton and with the Cutaneous Lymphoma Foundation. And thanks for hanging in there with us on this Friday evening. We've had some interesting technology challenges tonight. So I think we'll just dive right in. And we're here tonight with Dr. Lauren Pinter-Brown from the Chao Family Cancer Center at UC Irvine in California. Thank you, Dr. Pinter-Brown, for hanging in there with us. And thanks for joining us tonight. Really appreciate that. So, so we'll just all take a breath. So tonight we're here to chat about one of our favorite topics. We always get questions about this, but when does a patient talk to a dermatologist or a hematology oncologist? When should they seek a second opinion? Maybe you can share some of your thoughts on that. If someone's been newly diagnosed, maybe we'll take, when do you seek a second opinion? Maybe we'll take that one first.
Well, depends who the first opinion was, I guess. I think it's important probably to speak with someone that understands this condition well. So that's why I say it depends who the first opinion was with. If it's a physician who really doesn't know much about cutaneous T-cell lymphoma or cutaneous B-cell lymphoma, then I think it wouldn't be inappropriate at that time to go to a place where there's more expertise. You don't need to stay there, but just to make sure everything is appropriate, the diagnosis is correct, and you have some kind of plan about what to do, and then you can carry it out perhaps in what might be a more convenient setting like home, closer to home.
Right, closer to home. Excellent, excellent. And so let's just assume someone did that, and now they're being seen by a local practice. Is there a point in time, or when would someone potentially look for and seek out perhaps an oncologist versus a dermatologist if they're being seen locally? Maybe they've been getting light treatments or something like that. Is there a point in time when someone might want to get an opinion from an oncologist, or should somebody be seen by a hematology oncologist at the start? I know those are probably not, there's no black and white answer, right?
Yeah, there really isn't, because most people that have expertise in this area, it almost doesn't matter what their subspecialty is, because as an example, I'm an oncologist, but I know a lot more dermatology than most oncologists. And most of my dermatology colleagues that do this know a lot more oncology than most dermatologists. So if you're talking about, again, a place that has some expertise, I'm really not sure it's so important who it is, what their subspecialty is, but more important if this is an area that they understand and have experience with.
Well, that makes a ton of sense. And is there a point in time, let's, again, just trying to look through all the different scenarios, when you might seek to see an expert in the field? So maybe someone's been going along just fine and things are hunky-dory, but maybe they're seeing their disease change, or is that an appropriate time maybe to seek the expert opinion from someone that specializes in cutaneous lymphoma, say perhaps more so than the local dermatologist or oncologist?
And I think that would be really appropriate, because then maybe you need a new plan again. Things need to be reassessed. There needs to be a new plan made. So I think the times when I would wish that I would see somebody earlier would be immediately when things change, instead of people waiting until things get really out of hand and then coming in and asking for help. I always wish that when something changes, that people would feel comfortable coming in at that time, so that we can change course if that is what needs to happen.
Right. So and again, probably no black and white answer, right? But when, I'm just, and again, I think about it from my personal experience. I've been living with this for almost 30 years. So I have, I think, a pretty good idea of how my disease reacts and when I need to go and see someone about doing something differently than I've been doing. But maybe somebody that doesn't have that kind of experience with their disease, what kinds of changes might be kind of the tipping point where you say, oh, maybe I need to go back and have the specialist take another look?
I think that if you embark on a path, and let's say it's light therapy, and you get to an impasse and things aren't improving anymore, rather than continue with the same therapy for eons, it might be appropriate then. It might be appropriate if the skin lesions change somehow. They look different. That might be an appropriate time. Another time would be if you feel differently. Say you have some symptoms that you didn't have before. I think that's another good time to kind of just take a moment to reassess what's going on, and if you're still on the correct pathway with therapy.
Right. Well, that makes sense, because this is a long-term thing, right? And the disease could at some juncture change course or not, right? We don't know enough yet to be able to determine whose disease might change course and whose won't. So that's very good advice. Let's see. Trying to think if there are any other times when you might want to change your course of treatment. I mean, given where we are today with so many new potential things going into clinical trials, maybe is there a time when someone might want to think about a clinical trial? I know we're going to talk a little bit about that in next month's interview, but if someone has been going along and things maybe are changing, is that a time to think about trying something that might be in clinical trial that isn't currently available in the normal course?
It might be a time to look at it. The other two instances I can think of is, one, if you're doing a therapy that just isn't doing enough, maybe it's helping a little, but there's still a lot of disease. And another would be if you're not tolerating the therapy very well. Maybe it is working, but it's just not going to work for the long term. Then, in addition to times when the condition might change itself, those would be other instances where it would be appropriate to look at other options, and those might include clinical trials.
Right. Makes sense. And sometimes we actually continue with one therapy but add another therapy in addition. So if you're doing something topically to the skin that seems, to your point, that seems to be working but not to the degree that we would have hoped, then we might add something to see if we can't get a better response. Is that a viable, something that folks might want to think about too?
Absolutely, that's reasonable.
Yeah, and that might be a good time, right? And a good time then to go for that visit with the specialist and see what other options might be available.
Yes, that's correct.
Awesome. All right, so I'm going to dive into our second line of questioning here, and one of the things that people often ask us is, they go to the specialist, they have their treatment plan for cutaneous lymphoma, but then they go back to their primary care physician, and potentially maybe they're being seen for other kinds of things. Maybe they have diabetes, or they have high blood pressure, or just other things that people tend to have as health issues. So what should they be telling their primary care physician about their cutaneous lymphoma? How do you bring that to the table so that your primary care physician is also aware of what's going on?
Probably the most important thing is just to tell them that you have that diagnosis, because most primary care physicians may not be aware. They may have to do some reading. But in my mind, the most important thing would be to share that diagnosis and share the contact information of the physician that's treating you. Because probably the biggest problem I have, I'll give a very specific example, but it happens over and over. If a patient is on bexarotene, sometimes they need additional medications, and they're very specific. And they may be to control thyroid conditions or to control the fats in the blood. And the primary care physician might do their own laboratories and start changing around the medicines that I've put in and actually switch to something that's actually in conflict with the bexarotene. And it's just because they're not aware of that drug bexarotene, what it does. And there's no reason to expect that they would know. Out of all their patients, maybe they will never have a patient that's on bexarotene. So I think the most important thing would be to share the diagnosis and share the treatment, and mostly to share with your primary care physician who's caring for the cutaneous lymphoma, and ask them to please reach out if they want to make any changes, so that everybody can be on the same page and there's a more cohesive team.
Right, right. So I would venture to say that it's a great idea for people to keep track of, write things down, keep a log so that they can share it with their primary care physician. They have it handy if things change, so that everyone is up to date. And, are there specific, and I think I remember, and I know you'll correct me if I'm wrong, but there are some drugs that are routinely used for other conditions, and I can't remember if it's for high cholesterol or other situations that sometimes can actually cause what looks like or can be mycosis fungoides or a mycosis fungoides rash, and then when you stop that particular drug, it goes away. Is that true?
That's true. Yes, that's true. And there's a long list of drugs. Some of them are drugs that are not so common, and some of them are drugs that are very common. So at least when I meet someone, I go through their drugs. We try and figure out kind of the timing of things, when that drug started versus when the rash started. And then sometimes I need to call up the primary care physician that we're giving these drugs and explain to them why I think we should stop or change to another drug. So another good example of how everyone has to speak together as part of a team. Right.
Right. And is there, and we probably should have a list of all of those on our website, but I don't think that we do. So maybe I'll take that as a to-do takeaway, just so folks, can look at other things that they're on and make sure that everybody's on the same page and you're all in pretty good shape with regards to kind of this multi-modality scenario, right? Right.
Yeah, it might be an interesting idea. It's quite a long list. Some of the things that are on the list are really common drugs. And so it isn't just that you might be on that drug, but that the timing is such that it suggests that that drug might be causing the skin condition. So maybe I would be looking at something that somebody started and has been on maybe for the year before developing their rash. And at that time, I might think maybe they're related and it's worthwhile trying to get rid of that medicine or substitute it with something else.
Right. And see how that all works out.
Susan, hi, Susan and Dr. Pinter-Brown. It's Mike Grab off camera here. We do have some questions from the audience, so when you all are ready, I can kind of read those to you. And I don't know if now's a good time or if we can get to it in a few
Sure.
minutes. Okay. So
Go
some
for
of
it.
these came in ahead of time. And if anybody, we have over 30 people watching, so this is a record turnout at the gates.
Wow.
Dr. Pinter-Brown, you're really setting the pace for us here. So we appreciate that. And of course, we appreciate everybody's patience. Some of these questions came in ahead of time. If anybody has any questions you do want to post, please go onto the Cutaneous Lymphoma Foundation's Facebook page. We are streaming to several groups and several pages, but due to technical issues, we want any questions, please, to be posted under the video on the Cutaneous Lymphoma Foundation's page. So here is the first question. Is there enough data, Dr. Pinter-Brown? Are there enough numbers to tell how long someone will go into remission after having total skin electron beam radiation in mycosis fungoides versus, say, Sézary syndrome? And the person is also asking, given the blood involvement in Sézary syndrome, and that at least this patient understands in their perspective that total skin electron beam radiation just treats the skin, it seems likely that it might not be such a great choice in Sézary syndrome. Your thoughts?
I think that's very insightful. So to me, total body electron radiation wouldn't be my treatment of choice for Sézary syndrome for exactly the reasons that have been stated, because it really doesn't address the burden of cells that are in the blood. I suppose it could be combined with something that's systemic to address the cells in the blood, but when I'm thinking about treating someone with Sézary syndrome, I'm really thinking more about things that aren't directed to the skin necessarily, other than maybe steroid creams just to help with the feeling of the way the skin is, but more something that's going to go through the bloodstream and treat the cells in the blood and treat the cells in the skin.
Okay, great. And the next question, can you comment on the MRG 106 clinical trial, and in terms of the fact that, at least according to this patient, 90% of mycosis fungoides patients had some level of improvement. Is that the case on that trial? And this person also mentions that Dr. Quirfeld, who looks like is the primary investigator for that study, was their first dermatologist at Sloan Kettering and the best doctor they've ever had until that doctor left to start her own department at City of Hope. And so there's a follow-up question. It looks like a phase 2 trial will start soon. Can Sézary syndrome patients enroll in that phase 2 trial for MRG 106?
All right, so I'll pick the two questions related to the trial. We'll leave Dr. Corfield out of this. But the 90% improvement is a little bit of an overstatement. That has to do with any kind of improvement at all. So when we're looking at clinical trials, the benchmark would be 50% improvement. And there the response rate is lower. In this particular trial, at least what's been reported so far, more around the 49-50% range. And people with Sézary syndrome are not eligible for the trial. And the reason that is because Sézary cells don't express the same target that cells do with mycosis fungoides. So patients with Sézary syndrome are actually excluded from this particular trial because it's feared that their cells do not have the appropriate target and the drug would not be helpful to them.
Okay, great. Next question.
Right. And
go
actually,
ahead.
hey, Mike, can I
Yes.
just sort of have a dialogue a little bit about that? Because that was just a phase 1 trial, so a very small group of people. And basically, phase 1 trials are to test dosage and a delivery mechanism and so forth, to see if it makes sense to move forward, right? So,
Yes.
you know, it showed that there was enough of an improvement in that very small subset of patients to make it worthwhile to move into a larger trial where we'll learn more, but we'll also keep it very narrow, to your point, to mycosis fungoides, because this particular drug targets a marker that is more prevalent in mycosis fungoides than in Sézary syndrome. Is that
That's correct. That's correct. So
Right.
you're right. This is a great example of what a phase 1 trial does. This particular trial used many modes of administration. It started off with injecting the compound into tumors and then progressed to giving it under the skin and then finally intravenously and different periods of time intravenously. It's a really good example of how what the purpose of a phase 1 trial is, that you're really exploring what the side effects might be of a particular treatment. And moreover, you're exploring what the appropriate dose might be and the appropriate way of administering the drug. And so this is a really good example of a trial where patients were treated kind of each in little groups differently as the trial progressed. And finally, when the drug goes to what will probably be a phase 3 trial, one mode of administration will be selected that it is felt is the best tolerated and the one that works the best.
Right. So it's a long process, right? From phase 1 to phase 3, and then hopefully approval if things continue. And at any juncture from phase 1 to phase 2, it may show that it's not worthwhile to move forward. From phase 2 to phase 3, you may not move forward with that particular drug as well, right? So it's not.
That's true.
Again,
this is a good example. So this trial's been going on almost 3 years, and it just finished accepting patients actually this week with mycosis fungoides. And then people will start thinking about what the next trial looks like, and it will involve a discussion with the Food and Drug Administration as to what they think is appropriate. And so that discussion and arrangement of the trial, that too will take time until the trial opens up. And again, probably another couple of years before the trial has completed all its enrollment of patients, and then a period where people look at the data to understand how useful the drug was.
Right, right. And I know just in having been with the foundation, when I came over in 2011, we began talking to the folks with mogamulizumab that was then in early stage trial, and that has just finished up its phase 3 trial, and the data was submitted to the FDA, and so now we're still waiting, and that's, I think almost a 9 or 10, maybe not quite that long, but 9 years, 8 years from when I was aware to having it be commercially available. So it takes time. But the other piece is that it's really important to be able to get the right people to participate in the trial so that we can collect the data and move it through the process to ultimately become available for everybody if that's the right thing to do.
I think that's really important. I know that people get very frustrated with the length of time that it takes to do a trial, but people have to understand that it's done very thoughtfully and carefully, and that's done for people's safety. And so I know that it's very frustrating, and perhaps sometimes people wonder if things are moving too slowly, but the process as it's currently set up, again, to protect patients, it is a lengthy process that takes some time.
Right.
And on that mogamulizumab trial, is there a sense of when the regulatory agencies around the world, Dr. Pinter-Brown, will also be reviewing that data in terms of whether it's Europe or other countries? And
well, the drug is already approved in Japan. That's where it originated. Other countries, I'm not sure. In large part, it has to do with the company's efforts. And often, companies will wait for the Food and Drug Administration to complete their evaluation before moving on to getting approval in other countries.
Okay, great.
Right.
Okay.
And I was just going to say, I'll jump in there too, which is the other reason why we try to have connections and relationships with all the companies that are doing clinical trials so we can kind of stay on top of what's going on. And I know the company is hoping to be able to move relatively as quickly as they can for European approvals. It's a little different process than it is here in the US, but they are certainly looking to do that to the best of their capacity, but it'll be dependent upon the FDA's approval first. So,
All right. Shall we go to the next
stay tuned.
question?
We'll let you know. Yeah, go
Excellent.
ahead.
Okay. So do you find that people with cutaneous T-cell lymphoma tend to have a positive, smooth antibody test, like a false positive? I'm waiting to start bexarotene and interferon because I have some elevated liver enzymes and fatty liver, and they're trying to determine if it is fatty liver, liver disease, or cancer in the liver.
Okay, so I think the person's probably talking about smooth muscle antibody, which is a test that shows a particular autoimmune disease of the liver. Autoimmune diseases in general are when the person's own immune system turns against some part of their body. And I have to say that cutaneous T-cell lymphoma does not commonly cause autoimmune phenomenon. However, some people who have autoimmune conditions have a higher risk of different kinds of lymphoma, cutaneous T-cell lymphoma being one of them. And the reason why it's so important to know is that sometimes drugs or treatments may interact with the other condition. So as a good example is the interferon being discussed here can sometimes make autoimmune conditions worse. So it's very important to understand all of the patient's conditions so that you can make an educated and good choice about what the right treatment should be.
Okay. Are there any new treatments for lymphoid papulosis?
Lymphomatoid papulosis.
Sorry, thank you. Sorry,
Well,
I'm reading quickly.
All right, it's not so new, but brentuximab vedotin, which is an antibody that's linked to a chemotherapeutic agent, kind of a very gentle one, has been utilized and studied in lymphomatoid papulosis. Why I say not so new is that the data came out well over a year ago at this time. But I would say that's probably the newest addition to treatment for lymphomatoid papulosis.
Okay. Tammy says, thank you, Dr. Pinter-Brown, for giving me the best treatment there is. I'm so blessed to have you as my caregiver. Another person, cutaneous T-cell lymphoma mycosis fungoides, diagnosed in 2009, that presented first on my right breast and then on my left. I had radiation therapy for 5 weeks on each breast. My case is indolent, but I see my dermatologist and my oncologist regularly. I use triamcinolone if I have a rash.
Yes.
So that was her comment.
Okay.
Okay. Somebody else asking, what about diet? Any special diet recommendations for cutaneous lymphoma patients?
No. Good food, reasonable diet, nothing crazy. I guess the questions I get asked mostly about diet have to do with sugar. There's a lot of information, or I shouldn't say information, a lot of statements on the internet that sugar feeds cancer and you shouldn't eat sugar. And as a chocoholic, I have to say that everything we eat is sugar. And everything we eat gets broken down to sugar because that's the fuel of our body. So when people make comments like that, I'm not really sure how to take it. I can't imagine that a candy bar sugar broken down is so very, very different from a banana sugar. And so I would urge people to be moderate in their diet, and be a little thoughtful about some of these comments that, really don't make that much sense when you think about it. Other than that, I can't think of any particular diet issues. Susan, has anything come up that you've heard about that we should address?
I think in general, a healthy diet, eating whole foods versus tons of fast foods and just in general to keep your body functioning as best as it can is a good approach. And then I think every individual has to find what works best for them. Some people, being a vegetarian works better. I know I tried that, didn't work so well for me. I'm kind of an omnivore, so that works, but I think balance and common sense is probably the best road to go.
I would agree.
All right, next question. I have mycosis fungoides, I believe it says TINH, with pulmonary infiltration. I was treated with gemcitabine, but there was no improvement, and now I'm doing brentuximab, and both the skin and the lungs have improved, but the lymph nodes have remained unchanged. So now my hematologist is talking about transplantation, and from your perspective, if the chemotherapy, if some of these treatments have been effective, is it always recommended to do the transplant as a donor? So maybe in the case of the brentuximab, if that's effective, would it still be advisable from your perspective to go ahead with to do the transplant as a donor? So I guess to get a donor infusion, I'm not quite sure.
I think maybe the person's talking about transformed mycosis fungoides.
Oh.
That has gone to some other organ than the skin. And there's so many factors that come into play when we talk about bone marrow transplant donors. It's called an allogeneic transplant. But in general, if someone had transformed mycosis fungoides and it was in their lungs, and they were a good candidate for an allogeneic transplant, and by good, there's all kinds of variables that are looked at, somebody's function and their age and whether they have a donor and what their other health conditions are. But in general, in the best of all possible worlds, that person would be considered for an allogeneic bone marrow transplant.
Okay. Several other questions in the queue. I hope if it's okay to stick around for a few more minutes, if that's all right. Okay, so here's one. Is it routine to make a diagnosis on the DNA rearrangement test and an inconclusive biopsy result?
That's a great question, and it comes up a lot. And I have strong opinions about it. So those rearrangement tests, they're very, very sensitive. And so I personally don't allow my pathologist to make a diagnosis just based on gene rearrangement if the specimen, the biopsy, doesn't look like mycosis fungoides under a microscope. And the reason for that is that sometimes there's people that truly have mycosis fungoides and their gene rearrangement is negative because there's just not enough cells in the specimen, perhaps. And there's other people who do not have mycosis fungoides but do have gene rearrangement on their specimen because it's such an incredibly sensitive test. So in my practice, I actually don't use it any longer.
Okay. Moving on, what are your thoughts on the Stanford method for stem cell transplant for stimulating remission?
I don't have any thoughts because we haven't seen the data completely, but it is a well thought out approach to transplantation. I think we don't know whether that's the best approach, but it is an approach, and someone gave it a lot of thought. And for that, I commend the investigators because they have thought out an approach for a condition that's not very common and tried to make, if possible, the best possible outcome for our patients.
Can you explain what that method is versus other methods?
It involves using total body electron beam and different drugs than many transplant centers would use in a particular sequence. And I wouldn't be able to go into the specifics, but there are many different regimens that are utilized to prepare someone's body for allogeneic transplantation. Some of them don't involve radiation at all, and some of them may involve different drugs. And because transplantation is not done so commonly for mycosis fungoides, and because mycosis fungoides is not that common a condition, we do not have a really good handle on if there's one better way to perform the transplant than others yet, because each institution tends to have their own kind of plan about how they want to do it.
Okay.
And I think, sorry, Mike, I'll jump in here just to add too. And that's why it's so critical that all the clinicians worldwide come together at least once a year in different places and things to share the data from their center, and then to have conversations about the experiences, because especially in the arena of transplant, because there aren't that many people, it's a rare condition and rare that people would go through the transplant. So to try to bring that data together in a large enough volume to be able to analyze it and figure out collectively what might be a good approach is, to me, what's very exciting about the way all of the researchers and clinicians in this particular specialty have discussions and share the data and share their experience with the goal of having things be better for all of us that are living with this.
All right.
Right, and yeah.
Great. Several other questions in the queue here.
Okay.
I have cutaneous T-cell lymphoma. Does that preclude me from giving blood?
Yes, it does.
Okay.
That's a simple one, isn't it?
That was an easy
Simpler
one.
answer.
Every once in a while, we like to pitch you a softball.
Okay, it's good.
What are your thoughts on CAR T therapy for Sézary patients? Say we go from softball to hardball.
Well, there is no CAR T for Sézary's patients right now, because all of the CAR T constructs that are currently FDA approved, and most of them that are being studied, are against B lymphocytes. So they're mainly looking at B cell lymphomas. There have been several suggestions and kind of early forays into making CAR T products against T cells, but that's a little more difficult because T cells in our body are our immune system. Our B cells are too, but we can get along with a little less B cells than T cells. So it will have to be a very careful choice of what the target is, so that all the person's T cells are not removed by the CAR T product. So we're a ways away from having trials that are large that are for T cell lymphomas, but maybe it will come in the future. There's definitely some ideas about how to do that.
Mm-hmm.
Okay. What are your thoughts on brentuximab vedotin, etc., to treat cutaneous T-cell lymphoma mycosis fungoides stage 1B?
Oh, that may be a loaded question, but generally, for patients that have stage 1B, there would be other things that would be tried first, and those would be things that are directed towards the skin first, before we would move to a systemic drug like brentuximab vedotin.
Okay.
It was
All
stage
right.
1B, not 2B, right?
That was 1B.
Okay. Wanted to make sure I answered properly.
Yep. All right. My husband has Sézary and is now at MD Anderson. He's a patient there. Dr. Duvik is trying to obtain Targretin, which is very expensive. If that's not possible, photopheresis will be used. He's on a blood thinner, having had 3 TIAs, and stopping his blood thinner could be dangerous. We were told he could stay on it, but the bleeding risk goes up. Can you give your thoughts?
Well, I'm not sure why they were told the bleeding risk would go up, and unfortunately, we don't have the person asking the question here. I think perhaps if the anticoagulant is Coumadin or warfarin, that the concern would be that it takes less warfarin to thin the blood when you're on bexarotene, but that can be monitored with blood tests. So with careful monitoring, it should be safe.
Okay. Now here's an interesting one. My husband is enrolled in a trial for CAR T based on having the CD30 target. So it's happening now for at least one patient. So I guess
That's the target that people are looking at. And there is one or two institutions that are doing those trials. Very early days, but it's one way to target T cells. It's a little more specific.
okay. I know that's an area of a lot of interest, as you know, among patients.
It is, and among clinicians too.
But it's a little more complicated given this is a T-cell lymphoma, right?
Well, it just means that the CAR T product has to target something that's on a T cell surface rather than a B cell surface. And the initial trials were done with B cell cancers. So, it takes a while now to move away from B cell cancers and try and develop a different product that might work for T cell lymphomas.
All right.
I think
Go ahead.
one thing that is important to discuss with CAR T cells is in the lay literature, sometimes it's described so simply that you take the person's cells out and you engineer them, you fix them, you give them back, and they eat the cancer. But it's actually quite a bit more complicated than that because as the cells go into the person, they trigger a cascade of parts of the immune system that are then activated. And part of what needs to be learned about CAR T cells, in addition to what the product should be, is how we can best care for patients during the procedure so that we make it safer and safer. And then the next thing to learn, I guess, will be how long does it work for? If it stops working for someone, how can we make it work again? So I think this is a very exciting technology, but somewhat in its infancy. And I know that so many of my patients have come to me and say, take my cells, let's fix them up and put them back in. But it's really not that simple. And so we have to think about it with a little bit of caution and thought.
Okay. Next question. They've never diagnosed me with any lymphoma. I got close though. CD20 markers showed rare B cell. My last, I guess, report shows it was caused by a foreign invader. That would be my implants. I now have lumps that came up in both hands. My lesions are now isolated to my left eye, left earlobe on the back. And I guess on the back. My dry patches and bumps are on my hands. Any comments on BIA, ALCL, and any of these symptoms? My dermatologist said it's not what you're talking about tonight, I guess.
Read me again about the part before the ALCL. I want to try and understand what's being said.
Okay. So, never been diagnosed with any lymphoma. Got close. CD20 showed rare B cell, but my last shows it was caused by a foreign invader. That would be my implants. I now have lumps that came up in both hands. My lesions are now isolated to my left eye, left earlobe, and back. My dry patches and bumps are on my hands. And then, any comments on BIA, ALCL, and any of these symptoms?
That was I'm not sure what BIA, am I understanding you right? That's what you're saying?
BIA,
like
that's,
BIA?
yeah, BIA, ALCL.
Well,
Breast
breast
implant. I think
associated.
it's breast.
Okay. CD20 doesn't have really much of a role there. It's CD30 that has been mostly described with breast implants. So with breast implants, something's been described where a person can develop something that looks like anaplastic large cell lymphoma around the breast implant. It doesn't usually cause other skin lesions except for around the breast. And that's a T cell process where the cells have CD30 on them. Very, very rarely, people can have the same process with a B cell lymphoma, B like in boy, and that would have CD20, but again, would be local to the breast implant. So it's not something where you see the condition throughout the body normally. it's something that is very much associated with an implant, and the ones that have been described the most are with breast implants.
Okay.
So I'm not sure, so the situation's a little confusing.
Okay. Are there any new topical treatments for our itch?
Let's see. On the market, well, there's some coming down the pike. On the market, I'm not sure. There's a lot going on right at this moment, but there will be some things.
Any
so
sneak
right
previews?
Now, well,
there is a clinical trial, right?
Right.
Yeah, there's a couple of clinical trials, so we'll have to see what happens with those, and that's the best I can do. There's not a whole lot of new things on the market, but it's certainly something that people are interested in and looking at. So hopefully, in the upcoming year or months, there may be something that we could talk about that might actually be available to more people other than clinical trials at certain institutions.
Susan, anything you want to add there?
No, I think, all I'm aware of is just the one clinical trial currently that's really targeting itch,
And
topical itch.
which one is that? Do you remember? Was it Riziquimod or not? No?
No, it would be naloxone.
Okay.
Naloxone, which is just targeting the itch pathway, the neural pathways, but from a topical perspective.
You don't know how that's spelled in case somebody wants to look it up, do you, by chance?
It's naloxone.
Yeah. NAL.
Okay. NAL. Naloxone. Okay.
NAL. Oxone. OXON.
Okay. All right. Great. All right. Next.
The company is, I was going to say, the company is Elorac, ELORAC.
Okay. We'll try to post it in the follow-up. Here's somebody, my dermatologist is considering interferon because methotrexate with narrowband UVB doesn't seem to work. Brentuximab worked in bringing me down from stage 4 to stage 2B, but we're looking into controlling the skin manifestation. Your input would be highly appreciated.
Well, I haven't seen the person asking the question. And so stage 2B would be that the person has tumors. And I have to say, if you put 30 experts that do mycosis fungoides in a room, because we've done this, that you could not get most of us to agree what a tumor is. So when it's very hard to answer the question without seeing the person. But in general, there is a study looking at interferon with, I want to say PUVA, not narrowband UVB. It's quite an old study that did have patients that had tumor stage, and they did experience some improvement with that regimen. But there's a lot of ifs there because, we haven't seen the person. I think that would be the biggest problem giving anybody an opinion is that you actually have to get an opinion from somebody that can see you, particularly with this condition. It's so very important for the doctor to be able to see the person. Even in the past, people would send me pictures, and when I would actually see the patient, they wouldn't look anything like the pictures. And so I really personally now insist that I be able to see a person, because judging what their skin looks like is all important in figuring out what the right treatment is. And that's what we want to do, right, is pick the best treatment we can think of and go with it, and not kind of pick a whole bunch of things that may give side effects or may cost money or just not work very well, and then have to rethink it all over again.
Okay. Still have a few more. We've got more than 36 people watching, so some late night birds hanging in there and filling the queue with questions. Here's one. I was diagnosed with mycosis fungoides stage 1 in 2014, and since then I'm doing phototherapy, now 2 times a month. Do I have to keep on this treatment schedule for the rest of my life according to my doctor's recommendation?
That's a very controversial issue. So some doctors think that patients should have maintenance therapy, that is, their skin is clear and they continue to go for light treatments to keep the disease away, and it's true, it will keep it away for longer. Other physicians take a different approach and taper off the phototherapy at some point and wait for lesions to return before reinstituting it or some other kind of therapy. There isn't a right answer.
Okay. Next question. I've had both positive and negative T-cell rearrangements. However, my previous oncologist at Emory said her pathologist couldn't distinguish between follicular mucinosis versus follicular mycosis fungoides. I apologize if I mispronounced the former. My dermatologist pathologist said the same. Is this a common issue?
Well, there's two different issues being brought up. So one issue is the T-cell gene rearrangement, which we addressed. I wouldn't put a whole lot of weight on it. And then there's the issue of follicular mucinosis versus follicular mycosis fungoides. So I'll backtrack for people that may not know that terminology. Follicular mucinosis is a condition where next to where the hair implants into the skin, there's like a pool of mucin, which is kind of like mucus. And it's associated with mycosis, that condition is associated with mycosis fungoides. So sometimes it all has to do with the biopsy itself, whether the pathologist can see the mycosis fungoides or just sees the follicular mucinosis. And so it might take more than one biopsy and perhaps even different pathologists looking at the specimen to ascertain if the person just has follicular mucinosis, which is possible, or has it in addition to follicular mycosis fungoides.
Okay. That person that mentioned about the never being diagnosed with any lymphoma but got close with, the rare B cell and the breast implants mentioned, I wish you could see me. Maybe you could help me. Now my new symptoms are actual lumps. Maybe I could send you my reports and pictures, whatever you need, that sort of thing. So I don't know if that's something maybe Susan offline, they can contact you or something, or I don't know.
Or help, Susan can certainly help the person find someone in their area, wherever they are, that would have some expertise in that area, and perhaps being able to render a second opinion. Again, it's really so important for people to be actually seen physically by the physician, even if it means, making a special trip once. I think it's worth it, and there's certainly opportunities to get some help with travel expenses and that sort of problem. But sometimes it's really worth it just to even go once, so that the person rendering the other opinion can actually really see what you're talking about.
Okay.
Yeah.
My husband has stage 1B cutaneous T-cell lymphoma mycosis fungoides and has been on bexarotene, now interferon alpha 2B, and was given treatment options for methotrexate or brentuximab. With brentuximab, does the neuropathy tend to be permanent, and is fertility affected?
Two good questions. I would imagine fertility wouldn't be affected, but I'm not sure it's been particularly well studied. And I'm saying that based on the chemotherapeutic agent that's attached to the antibody, that it shouldn't cause infertility. The neuropathy, most of the time will improve, and in some people goes away if it happens. But probably for some people, for a small group of people, it is long lasting for them. It usually occurs for most people after they've received many doses of the drug. Kind of statistically, it would be around the 8th dose. And it's something that can be very closely monitored to try and actually prevent it from happening or prevent it from being a bothersome problem.
Okay.
And I would say, sorry, I'll just jump in, having talked to some folks. I think it's really important important for anyone that is on brentuximab to pay close attention and don't kind of shrug it off as, oh, you know, it'll go away or I don't have to worry about it. I think it's really important that folks tell their physicians when they first have any symptoms so that either the dosage can get monitored or managed, because every person's so individual, you just don't know what that impact is going to be on a specific individual. So, you know, I think it's important that people pay close attention and don't be afraid to tell your doctor that you're having a symptom so that you can better manage it.
I think that's
and then
so
the other
important.
thing, yeah, and I think people sometimes are afraid. They don't think, oh, well, it's no big deal. It's not bothering me today. But I think especially in this instance, it's really important to share that with your physician. Then you can figure out what to do about it. And then the other thing I would share is hopefully soon, we just had some folks from our Medical Advisory Council put together a chart with all the different treatments and fertility impact. We'll be loading that up on the website. They're finishing it up. So, you know, it's something that most people don't think about because this disease typically happens in older people, so it hasn't been a big issue or studied, like Dr. Pinter-Brown said, but there, you know, I think it's an important thing because we do have younger people, myself included, and I think it's something that folks should at least be aware of and check out just in case, so you don't get blindsided. So that'll be up on the website. Give us a little bit of time, but if you're in that arena, we will have kind of a chart that you can look at to kind of help guide and direct. And then you always have to talk with your physician, of course.
Great. We're up over 40 viewers and counting. Do you see results with interferon, Dr. Pinter-Brown? Have you seen good results? Yeah, good results with interferon?
Sure. It's one of our older therapies. Interferon has been used since the 80s. I think in the appropriate patient it can work really well, but it's not going to probably work for everybody. Okay.
I have mycosis fungoides with, and I'm going to mispronounce this as well, poikiloderma variant. I'm being treated with bexarotene, methotrexate, and UVA1 phototherapy. About a month ago, I found a lump in my groin, and it's confirmed that it's a lymph node. Should I be concerned? I'm at stage 1B.
Well, I mean, the groin is a very common area to feel lymph nodes because lymph nodes have territories, if you will, that they're responsible for patrolling. And the groin lymph nodes are responsible for our legs and our feet. So many of us walk around barefoot, we step on a pebble or we scratch our leg or whatnot, and then those lymph nodes in the groin get the message and they're trying to do their job and they enlarge. I think it would be really important to bring the observation of the lymph node to the person's treating physician, and the treating physician will make a determination based on how large it is and what it feels like, whether it's something to be worried about and should be biopsied. So not all lymph nodes in the groin are abnormal, nor do they need to be biopsied. But it's really important to share that with the treating physician, that observation.
Okay. Can you recommend let's see, Susan, this will be a question I guess the foundation can follow up with. Can you recommend a colleague, doctor, friend who might be more familiar with the condition here in the Philippines? So I don't know if on the website, do we have some references for that part of the world?
I don't. I have to go back and look. I know we've had some engagement with folks from the Philippines, and off the top of my head, I can't remember if there are any experts in the field that are part of the International Society of Cutaneous Lymphomas in the Philippines. I don't think so. I think it's one of the areas of the world that we're a bit challenged with regards to having experts in the field, and you know, that's one of the issues that we deal with even in the U.S., where we have a number of experts in the field, but not every cancer center, not every every state has someone that people can travel to easily. And then once you get out of the U.S., it gets a lot more challenging. And I don't know, Dr. Pinter-Brown, if you, yeah.
I can't think of anyone, but you've brought up a good avenue of investigation. We could look at the International Society's membership or directory and ask them if they have someone.
Yeah, and we're also a member, so we can do that pretty easily. That's usually my go-to. I'll also share that we are starting to capture data worldwide from patients with from our Lymphoma Coalition patient survey, and we've done a subtype report for cutaneous lymphoma, trying to ascertain treatment options, access to experts, and so forth worldwide to get a better handle on where the gaps are, where we need to do some work to try to figure out how to make sure people in all different countries have access to experts and all of the treatments that are available everywhere. We're not going to solve that issue today or any time in the near future, but it's something that we're really looking at and trying to figure out strategies for how to best make sure that everyone, no matter where you live, can get access to experts and to the treatments. But anybody can contact us, and we'll do our best to try to connect you to either experts in the field that we're aware of, or even a local patient organization that knows lymphoma experts in a country, even if they're not cutaneous lymphoma. At least if you can get somewhere where they know lymphomas, and then have those physicians reach out to experts in the field to collaborate, is probably the next best thing.
Okay. The questions have been flying by. I saw something from Michael Young, the board member of the Cutaneous Lymphoma Foundation, giving a shout out to Dr. Pinter-Brown for her great work, and to you, Susan. But it flew by, so I didn't see it. But just continuing on with the questions here. So my husband is using gabapentin now to help control his itch. Have you seen much success with this drug?
Yes, gabapentin can be helpful. The way gabapentin works is by affecting the nerve conduction of pain. The kind of itch that happens with mycosis fungoides is more related to like pain and nerve pain than it is to things like histamine itch, like we get when we have a mosquito bite. So things like antihistamines don't work quite as well as things like gabapentin that are directed to kind of altering how the message of itching gets up to the brain. And there's other drugs that are like gabapentin, that have also been utilized.
Okay. Becky says, what a blessing y'all are for us. Thank you, Becky. Here's another one. I have primary cutaneous B-cell follicular center non-Hodgkin's lymphoma. I wish I knew more about it. I had lumps on my head which were treated with radiotherapy. I now have multiple lumps all over my body under my skin. I had a biopsy on one, and it was just fatty tissue. Should I be concerned about the other lumps? I'm in Northern Ireland.
Fatty tissue, the medical term for that is lipomas. They're benign. They're really, really common in people's bodies, and they feel a little bit different, to be honest, than primary cutaneous B-cell lymphomas, and they look a little different too. So I would say if the physician has looked at the other lumps and sees that they're the same or feels that they're the same as the one that was biopsied, that there's no need to biopsy every single one. Primary cutaneous follicular lymphomas, they tend to be somewhat reddish, and lipomas are not, though they may both be kind of raised and have a kind of a round, smooth feel to them. The color change is one thing that makes them different, and sometimes just the way they feel. Lipomas are a bunch of fats, and they're kind of squishy and soft. And primary cutaneous follicular lymphomas may be a little bit more firm. So I would make sure that you've shown the other lumps to your physician, and then let them use their trained fingers and eyes to figure out if they all seem like lymphomas and no worry, or if they have some concerns about them and need further biopsy.
Okay. Next question. I have mycosis fungoides. How do you feel about treatment with acitretin? I have 60 to 70% coverage and have, now they wrote corny, C-O-R-N-Y. I'm guessing they meant coronary disease, and have had, let's see, it jumped off the page, something about a liver, I don't know. I lost the comment. They're coming in so fast. So I don't know how you feel about acitretin for somebody with coronary disease and apparently some kind of liver issue.
Well, acitretin is a retinoid in the class of drugs like bexarotene. It doesn't cause as much in the way of problems with the fats as bexarotene might. It has activity in mycosis fungoides. I guess it depends what the liver problem is, whether it's a good drug or not. Again, this is a really individual question that would have to be addressed to a physician that actually knows the details. But it's a legitimate way to treat people with mycosis fungoides for sure.
Okay. Are Sézary preps equally as helpful as flow cytometry in diagnosing Sézary syndrome? My Sézary prep showed 28% of lymphocytes with morphologic features consistent with Sézary cells, and the flow showed 4.2% abnormal CD4 positive and CD7 negative T cell population, and also 14.8% population of T cell large granular lymphocytes. I was told not to worry about these results. Would you agree?
Yeah. Well, I'd have to see the flow cytometry, but let's address the first question, which is the easiest. So Sézary's preps, they're not as good as flow cytometry probably, and a lot of places are getting away from doing them. I haven't used them in probably 20 years. Flow cytometry is really specific and much more sensitive, I think. And then the specific flow cytometry results, I think really I wouldn't feel comfortable commenting on without knowing the full picture of this particular person's health and labs.
Okay. I've got stage 4 Sézary syndrome, and I've got 90% rash and a lot of, let's see, ice excess skin. I'm not sure what that means. On both ears that are developing lots of folds behind the ears and scalp. Been having chemotherapy for the last 4 months. Let's see if looks like that was all they posted. I don't know if there's anything you wanted to comment on that statement or.
No, maybe if there's a question, it'll be floating by again soon.
Okay.
How are we doing on time?
Yeah.
I just want to be conscious of Dr. Pinter-Brown's
Yeah, that's a good point.
time.
Do you have
You're asking me?
Yeah.
Yeah.
I'm fine.
You okay? Okay.
All right, just checking.
Okay. I'm on
We're going to do
stage.
the marathon here.
This is a record. I'm on stage 1A. How often should I do tests like CAT scans, et cetera, to make sure I still stay on the same stage?
Good question.
Well, CAT scans aren't usually recommended for 1A, so I'd say probably you don't have to do them unless somebody feels a lymph node or there's something that changes with the way that you feel. So personally, in my practice, I wouldn't be performing CAT scans.
Okay.
But I would be examining someone and examining their lymph nodes.
I think we're coming toward the end of the queue. I'm going to do a quick scan backwards. Do the side effects seem to worsen, stay the same, or level off with interferon alpha 2B injected 3 million units 3 times a week?
The side effects actually lessen and they level off. So when you give interferon at first, you might get things like fevers or chills or, and it happens with the first couple of doses. And then after that, that goes away. And the other side effects, which may be fatigue or a little nausea, they tend to level off and even kind of lessen a little bit over time.
Okay.
And I'll just share, I was going to say, I'll just jump in with my own experience on being on lots of interferon, I always gave my shots at night and then slept through any of those flu-like side effects. And usually by the next morning, I was in better shape. So just one person's
That's a good
experience on
suggestion.
how to deal with that.
Yeah, that's what I tell my patients too.
Okay, somebody's asking, when can I take a hot shower again?
Well, the trouble with hot showers are they dry out your skin. And I know they feel great when you're doing it, but in the end they kind of they dry out your skin. And then they dry out your skin, then you get more itching. So I would say, again, our key word here is moderation. We don't want hot showers. We kind of want warm showers, tepid showers.
Okay. And one quick follow-up, that person that was asking about the CD20, apparently they did have CD20. So CD20 with rare B cells are nothing to worry about? This was a skin biopsy.
That's correct. So the pathologist is just commenting on what they see. And sometimes you see 1 or 2 B cells in a specimen, and we don't really make a big thing about them. They're just there trying to do their thing, help along as part of the immune system.
All right, I think just one more. Is Sézary always stage 4, or can it be an earlier stage if the Sézary blood count is not so high, like, for example, 600 to 1300, I'm guessing that's cells per milliliter?
There's the way the staging goes, when somebody has erythroderma or they're all red, if they don't have significant blood involvement, it's stage 3. But I'm not sure I'd get all hung up in the stage numbers. They're there to help us when we do clinical trials so that we compare the same patients, between trials. And this is a whole big discussion, Susan, isn't it, about what do we do when we see numbers related to stages, like how people do. So I'll just get into it. I mean, first of all, we don't have very good numbers for now. The numbers that you see on the internet are old, like 20 years old. And things have certainly improved because I've been doing this more than that period of time. And you can see how different the outcomes are than they were 20 years ago. So it hasn't been studied real well how people do right now. But even if you did have a current number right now, you'd have to realize that that's a statistic. So it means nothing to you, or very little to you, because one person might do extraordinarily well, one person might do maybe very poorly, and then there's going to be the people in the middle that are the statistics that you see. But how would we ever know who those people are without treating them? So I would caution very strongly about getting too hung up with the stage and what the stage means, other than some very general concepts about the difference between somebody having stage 1 disease and somebody having much higher stage disease. And I really want everybody to remember about the tremendous amount of research that's being done in this area and the increase in drugs that we get every single year, which is going to impact greatly people's outcome. So this is really a moving target.
All right, and we're just about to wrap up. A couple people, you are so appreciated, ladies, more than you'll know. Somebody else said, thank you for answering so many questions. You've been more helpful than the 5+ physicians I've seen for this. One person, my recent biopsy showed CD25 patchy membranous staining of some of the atypical intraepidermal and dermal lymphocytes. The pathologist feels there may not be any clinical significance. What can you say about this?
I'd say that's probably true. We used to do CD25 staining. There was a drug on the market called denileukin diftitox, which some people used to look at CD25 staining. It actually probably isn't even important for that drug. And I can't think of any other instance where it's important other than diagnostically. There are some T-cell lymphomas that could present in the skin that are very strongly CD25 positive. but a rare cell here and there, I don't think, again, I think it's the pathologist being descriptive about what they see in the slide, just trying to describe to you in words what they see under a microscope. In case someone ever asked, did you do this test? What did it look like? They're just trying to give people information and be as descriptive as possible in communicating what they saw with their eye under a microscope.
All right. Well, we're going to wrap it up there with the last person commenting, just saying, so glad you're bringing up how much better the therapies are. They give us a better quality of life, and I think they give hope, don't they, Dr. Pinter-Brown and Susan?
Yes, to the clinicians and the patients.
Exactly, exactly. And I can vouch for all the work that's being done on so many fronts, not only in developing new treatments, but also all the work that's being done to try to understand the underlying biology of this disease, because the more we learn about the disease itself and how it functions and how it's different in different people and in different iterations, really then helps figure out what treatments are best targeted to which person. And hopefully someday, at least in my dreams, we'll know how this disease functions, we'll know what we're looking for, we'll have diagnostic tests that can tell us who has what, and then we'll be able to have treatments that can treat that specific person's iteration of the disease. And we're not there yet, but that's all the work that's being done on our behalf everywhere around the world. So I'm excited and hopeful for what's going to come down the pike in the next, 3, 5, 7, 10 years. It's my 2 cents.
Well, that's it, Susan. I'll turn it back over to you for you and Dr. Pinter-Brown, if you have any final closing statements or comments.
Sure. Well, I will just say thank you so much, Dr. Pinter-Brown, because we were on an hour before we had all the technical difficulties, and then thank you, Mike, for figuring out a way to get us on live tonight. I really appreciate all of that hard work behind the scenes that wasn't noticeable to anybody that was waiting for us. And I really just want to say thanks to everybody who hung in there and waited for us to get it all figured out. Technology is great, and sometimes it is not so great when it doesn't work. And really thanks, Dr. Pinter-Brown, for hanging in there and answering all the questions and staying with us tonight. And for everybody that hung in there, and if that person was joining us from Ireland, it's really early in the morning there, so that's amazing. That's really amazing. So
look at how dark the door got behind Dr. Pinter-Brown. I mean, she's on the West Coast. That tells you it's a late night.
It's dark here.
Yeah, exactly. So, I don't know, Dr. Pinter-Brown, anything else that you want to share before we sign off for the evening?
No, thanks for hanging in there. I'm impressed, and keep asking questions.
Yeah, I think that's a good way to end the night. And I'll just let everybody know that our next program on Facebook will be on April the 9th. It'll be 6 p.m. Eastern Time, and we're going to do a little deeper dive into Clinical Trials 101 with Marianne Tawa, who's a nurse practitioner from Dana-Farber, and Dr. LaRocca from Dana-Farber. So bring all your clinical trial questions, and we'll do our best to get them answered next month. And for anybody in the Seattle area, we'll be having our evening Ask the Experts program next Friday night with Drs. Shustov and Shinahara from the University of Washington. So if you're going to be in Seattle, come on out Friday night, and I will see you there. And if not, we'll see you hopefully April 9th on Facebook. And in the meantime, have a great weekend. Happy St. Paddy's Day for all of those who are celebrating the green, and enjoy your weekend. Thanks, everybody, for hanging in there with us. We really appreciate it, and we'll see you soon. Have a good night. Take care. Bye.